So I'd like to welcome Kate Scrivener and Lauren Christie to present tonight about telerehabilitation. Kate is a physiotherapist, a researcher and an educator who's a senior lecturer at Macquarie University here in New South Wales, and she's allied health lead at a large national rehabilitation provider, Concentric Rehabilitation, which started in Sydney. She's also a director of the StrokeEd collaboration. Lauren Christie is an occupational therapist, a researcher, and currently is a senior implementation science research fellow at St Vincent's Health Network in Sydney. And she's an associate presenter with the StrokeEd collaboration. Kate is going to be presenting by recording, and so Lauren's going to start first. So again, questions in the Q&A at the bottom, please, and I'll hand over to Lauren.
Thank you very much, Annie, and thank you everyone for coming along this evening. I'd just like to start by acknowledging the Gweagal people of the Darawal Nation, the traditional custodians of the lands on which I have prepared this presentation and am presenting from this evening. I also acknowledge the traditional custodians of the various lands on which you are learning and working from today, and any First Nations people participating in this session. I pay my respects to elders past, present and emerging. This image is of the beautiful national park, which I'm so fortunate to have on my doorstep. So today I will be discussing some of our preliminary work that's been focused on the implementation of the delivery of constraint-induced movement therapy programs via telehealth. And I would just like to start by acknowledging my co-investigators on this project who are there listed on the screen. Constraint-induced movement therapy, or CIMT, is an intervention that was developed to overcome upper limb impairments after stroke. CIMT programs have evolved over time with a range of modified versions of the original protocol now published within the literature. However, it must have three core components: intensive graded practice using the affected upper limb to enhance task-specific use. Within the original CIMT protocol, that was for 6 hours per day for 2 weeks, but the number of hours of training and program duration now vary from protocol to protocol. The second core component is wearing of a mitt restraint on the non-affected arm to encourage and promote use of the affected upper limb. And the final core component is a transfer package that focuses on supporting participant behaviour change and adherence to the CIMT program. The transfer package includes monitoring mechanisms such as daily administration of the motor activity log to track the amount and quality of arm movement, a behavioural contract set at the start of a program to outline expectations and encourage adherence, and a daily home diary and written assignment of practice that's completed at home each evening during a program to encourage generalisation of use of the affected arm into day-to-day life. CIMT is currently the only upper limb intervention that we have listed as a strongly recommended intervention within our Australian and New Zealand clinical guidelines for stroke management. Yet we know from audits that have been conducted, most recently within our national audit conducted by the Stroke Foundation here in Australia, that only around 11% of eligible stroke survivors receive CIMT. Now, my PhD studies are focused on overcoming the barriers to CIMT delivery and supporting teams to successfully deliver CIMT programs in practice. During the Australian Constraint Therapy Implementation Study of the Arm, or Active Arm, we supported 9 neurological rehabilitation teams across southwestern Sydney here in Australia to successfully change their practice and deliver CIMT more routinely in care. And we were able to increase the delivery of CIMT in practice from less than 2% of eligible people being offered CIMT at baseline to around 80% of eligible people being offered CIMT and just under 50% receiving a program at the end of that implementation study. However, the work that we conducted was very much focused on the delivery of face-to-face CIMT programs, as it was prior to the COVID-19 pandemic, with only a small proportion of the number of programs delivered being delivered via telehealth or via a hybrid format of delivery, with a mix of sessions at home and within the clinic. So during the early phases of the COVID-19 pandemic, I was contacted by an occupational therapy colleague, Jessamy Boydell, and a physiotherapist, Annie Mahag, from the United Kingdom, who were aware of our work in Australia, focused on implementing CIMT programs across southwestern Sydney, with the idea of us working collaboratively together to develop a suite of resources that were freely available to clinicians to support them to deliver CIMT via telehealth, having seen the rapid move away from the access to face-to-face healthcare. So in collaboration with Anna Kilkenny, a physiotherapist from Waikato in New Zealand, we designed a suite of resources to support clinicians, stroke survivors and their supporters to conduct a CIMT program via telehealth. So our website includes therapist learning modules to educate clinicians about the different components of a CIMT program, considerations of how to set up a program via telehealth, as well as practice libraries with ideas for shaping tasks and functional task practice, and step-by-step booklets for therapists, participants, and supporters to help them work through a 3-week CIMT program via telehealth. We also have additional video and written resources to support both CIMT participants and their supporters to prepare for a CIMT program. So we're now using these resources combined with other remote implementation strategies to support and evaluate the feasibility, acceptability, and the potential scalability of delivering CIMT via telehealth within routine care. So the aims of this component of our study were to explore what therapists perceive to be the barriers and facilitators to delivering CIMT via telehealth. And tonight I'm also going to describe our development of a behaviour change intervention to support tele-CIMT delivery. So we knew from our previous work with ActiveArm, supporting 9 teams to change their practice and to deliver CIMT routinely within their existing resources, that the website alone, providing online education, was unlikely to be enough support for clinicians to change their practice and to deliver CIMT regularly within routine care. So we had occupational therapists and managers who are currently delivering outpatient neurological upper limb rehabilitation, who were recruited to our current study, who are working within 3 metropolitan health services here in Sydney, and we have a 4th site that's just about to come on board down in Melbourne. The facilitators and barriers to CIMT adoption within a telehealth context were extrapolated from our previous research in a similar therapist cohort from the ActiveArm project, in collaboration with my colleague there on the screen, Ella Howes, who's a behavioural scientist who's based at the Centre of Behaviour Change at University College of London. We then developed a tailored behaviour change intervention based on our learnings from our previous research, and also with the knowledge that we wanted to make sure that this was something that could be delivered 100% remotely, particularly with the ongoing challenges of the COVID-19 pandemic and lockdowns in certain areas. So based off our learnings and our development of our initial tailored behaviour change intervention, we then presented it to therapists and their managers during a focus group where we talked about what some of the additional barriers and enablers to delivering tele-CIMT might be. We confirmed the components of our behaviour change intervention and further refined it to ensure it would fit within their local context and resources, and what would be feasible to deliver both remotely and within a public health context. So what are some of the key barriers to delivering CIMT in practice? Well, we knew from the Active Arm project, some of the core barriers to CIMT delivery include lack of therapist knowledge about who would be suitable or is eligible for a CIMT program, how to structure a program, and how to deliver a program with fidelity, including all of the core components. Because of this lack of knowledge, where therapists report often knowing about CIMT but not how to deliver a program, they often report a lack of skills and a lack of confidence. And this then often contributes to why they don't offer this intervention to people who may potentially benefit from it. We also knew from our work within Active Arm that because this is a complex intervention that does require resources to be shifted often in order for it to be delivered, having management buy-in and support is really important. Additionally, teams need resources to help them to deliver CIMT programs, including having therapy space, access to everyday therapy items, the MITch restraint, as well as the time, with the use of collaborative approaches really important. What we found within Active Arm was that generally, if teams could work within an interdisciplinary manner, so occupational therapists and physiotherapists working together to deliver CIMT programs, sometimes with additional support from either students or allied health assistants, it was far more feasible for them to deliver those programs, including group-based programs, and to then build it into their routine practice, with teams becoming far more efficient at delivering programs the more that they practiced it and worked together as a team. So based on what we knew from Active Arm, as well as some of the potential barriers to delivering CIMT via telehealth, we developed this proposed behaviour change intervention made of 3 key components. The first was delivery of therapist education and resources using the TeleCIMT website that we had developed together as colleagues. The website, as I've mentioned, includes those free resources for therapists and stroke survivors and includes educational webinars and videos to help support delivering a 3-week TeleCIMT program. So after completing the online education modules, each of our 3 recruited teams then participated in a 3-hour online workshop. And this was to practice the skills of delivering CIMT via telehealth, including practicing working on the environmental setup for the home, the opportunity to ask questions, and to develop action plans to address any additional anticipated barriers to commencing TeleCIMT within their service. Finally, after each team had completed their online training and attended their virtual workshop where they'd worked through a case study and practiced those skills of delivering TeleCIMT, we started a monthly community of practice. Now, this is held once a month via Microsoft Teams, where each of our 3 sites dial in and they share their achievements, as well as problem solve together any ongoing barriers to TeleCIMT delivery. And that really provides a nice supportive environment to help those teams to change their practice. So within the focus group that we conducted with therapists and their managers, there was some additional barriers raised about delivering this behaviour change intervention remotely. There's obviously challenges around training and the impact on work hours. The therapists were very clear that they wanted an opportunity to do a practice run of delivering CIMT via telehealth prior to delivering it in real life, for want of a better term. And that's why we introduced that hybrid workshop with the practical case study to provide opportunity to practice those skills. They also raised some challenges, again, that were consistent with what we've heard from our previous work within Active Arm. Staffing changes and the need to have contingency plans for staff leave and redeployment was really important. So looking at opportunities to train additional staff, or looking at possibly a train-the-trainer model down the line if we find that this model of delivery is successful. One of the great things about the TeleCIMT website is that the online education modules are freely available to all, which means that more than one person within the team could be trained using those web resources. We also talked about the involvement of students and allied health assistants and what components of a TeleCIMT program would be appropriate for a student or allied health assistant to support versus what components would need to be more closely overseen by the treating clinician. And then looking at the intervention content. So we provided an inbuilt quiz following completion of the online learning so that we could then refine our workshops to address any identified gaps in knowledge, things that people had missed when they'd completed the online education. Resources was also of importance. So what people talked about were some of the IT challenges that can come up. Another barrier which we hadn't anticipated being quite so large of a problem was internet access. And we've actually provided a portable Wi-Fi dongle to participants who don't have internet access at home if it's the only limiting factor preventing them from participating. We've looked at using everyday items wherever possible to deliver TeleCIMT so that people aren't having to send big packages of resources out to the person's home, and trying to really personalize goals so that they're set around things that are important and meaningful to the individual, using items that they already have at home. We've also looked at devices used to access and connect with the therapist. So each team has one spare webcam that they can loan out if needed. The community of practice has been working really well. We've just selected a platform that's accessible for everyone of our participating sites and established some business rules so that people feel able to share their experiences and share amongst the broader group, as well as sharing any tips and quick wins. So some of our key learnings that we've found from Recite so far, we've been surprised by some of the challenges associated with internet and device access, which have been far more significant than what we initially had anticipated. Lack of equipment has also been raised as a potential challenge, but people have been looking at some very creative ways to use items around the home. There's also been some additional learning needs identified in relation to people knowing how to connect to the various platforms to complete the TeleCIMT with their therapist and knowing how to hotspot. So a lot of the things around the environmental setup have been very important, and creating some additional simplified guides to help people with connecting to their TeleCIMT call. I mentioned earlier that we've run these series of components sequentially for our behaviour change intervention. And what we've used is the capability, opportunity, motivation, behaviour model to look at changes in clinician behaviour in relation to TeleCIMT delivery after they've received this package of support. This is a very commonly used framework for designing and evaluating behaviour change interventions. We had therapists complete the brief COM-B questionnaire at baseline after they'd finished their online training and after delivery of the online workshop to evaluate changes in their perceptions of their ability to deliver CIMT via telehealth. The questionnaire is comprised of 8 questions, and we added an additional 3 questions to further explore clinician confidence and then analyse the outcomes descriptively. So we had 11 occupational therapists who were recruited and completed the questionnaires at all time points. Barriers to TeleCIMT identified were consistent with some of our previous studies as mentioned. around lack of therapist knowledge, skills and resources, as well as challenges for participants, including technology access, internet access, as well as the increased need for carer support and involvement in a program because the person's completing it within their home with less direct face-to-face time with their therapist. So we can see here when we look at the green bars, from pre-completion of the online education modules to post, so if we're comparing the green to the blue, we've got improvements in clinician perceived knowledge and skills. However, we know that knowledge alone is often insufficient for people to change their practice. Following delivery of the online workshop, you can see that there's then been improvements in clinicians' awareness of resources to support tele-CIMT delivery and further improvements in their perceived skills and significant improvements in their belief that they have a clear plan of how they're going to deliver CIMT via telehealth. So you can see here, this really highlights the benefits of having that additional online workshop after the online education to give people the opportunity to practice the skills before delivering a program. Similarly, you can see here across our measures of confidence in their ability to deliver tele-CIMT following the guidance we'd provided, their ability to deliver it even when there was little time, and confident they could deliver tele-CIMT even when the person wasn't particularly motivated. All areas also improved. So in terms of what we've found to date with the ReSight study, there are additional challenges associated with delivering complex stroke rehabilitation interventions like CIMT via telehealth, including issues in relation to technology access and the need for additional carer support. What we have found though so far is that remote delivery of education and support to clinicians has been feasible and has resulted in improved clinician knowledge, skills and confidence when they're given additional follow-up support. Now, this is very similar to the findings that have been found by my colleague, Dr. Laura Jolliffe, that there is this need for active facilitation strategies to really support clinicians to change their behaviour. And that's similar to our findings previously with Active Arm. In the next step of this program of research, we're now going to evaluate the feasibility and acceptability of delivering tele-CIMT programs and what the associated outcomes are for stroke survivors in the remote constraint-induced therapy of the upper extremity study. And we've just recently had our protocol published. It's open access in Frontiers in Neurology in a special issue that's focused on home-based rehabilitation. If you scan the QR code there on your screen, you'll be able to access and go straight to the paper. Now, that project will provide us with a really unique opportunity to evaluate the potential scalability of tele-CIMT delivery with online implementation support, which we hope may then improve clinician knowledge and skills and increase the number of stroke survivors, particularly those in regional and remote areas of Australia who can access CIMT. We'll use the findings from this initial study to further refine our training materials and supports for CIMT training for therapists and embed tele-CIMT into practice at those participating sites. And we're very lucky to be supported by both St Vincent's Clinic Foundation, as well as a grant from the National Stroke Foundation here in Australia to support that research project. Just finally, if you are interested in what I've discussed today, as I mentioned with my colleagues Jessime, Annie and Anna, the tele-CIMT website is a freely available resource. We would encourage you to go and register, and then the QR code is there on the screen that you can then access all of those resources, and we would then love to receive your feedback on how you find the website and how it helps you to change your practice. So I will stop sharing there for a moment and We might just have a brief pause whilst I bring up Kate's presentation.
Now, there aren't any questions so far, Lauren, but one question that often comes up when I talk about CIMT, people want to know what's the typical length of a program and what sort of contact do the participants have with you, the therapist, if they're doing this by tele-CIMT? Do they ever see you in person, or is it all done remotely?
Thanks, Annie. So you'll see within the published protocols, there's lots of variation. We have used as a guide the recommendations within the Australian and New Zealand clinical guidelines for stroke management that say that people need to be receiving at least 2 hours of active practice per day for at least 2 weeks, with midwear for at least 6 hours per day during a program, as a bit of a guide of how we've designed the tele-CIMT program. Now, because people are receiving less therapist input, which I'll describe in a moment, we've suggested the program should be run for 3 weeks to maximise that intensity of practice. What we suggest is that people have a 1-hour session with a therapist 3 times a week for the 3 weeks, and on the in-between days, they have a brief phone call. Now, the person is still expected to do 2 hours of practice per day. So they're required outside of that one-to-one therapy session to do at least an additional 1 hour of practice on that particular day, and 2 hours either independently or with supervision from their supporter on the other days where you're doing a telephone call. So that reduces some of the need for direct input from a therapist. But what we're really looking at as one of the reasons why it's important that we do this formal evaluation and the ReSite feasibility study is to look at whether programs can still be delivered with fidelity using that model, whether people who participate adhere to the program enough, are practicing enough to gain the benefits that we would expect to see from if someone received a more traditional face-to-face CIMT programs where they're getting 2 to 3 hours of direct therapist contact per day.
Okay, thanks. And somebody's asking, which is a fair question, if they're using the transfer pack in the on the website, it's in a PDF format, wondering whether it's possible to get a Word version of documents like that so that they can change the name of the patient if they're using it.
We actually have placed all the documents on the website are actually also available in an editable Word format, and there's a password that's listed on the website as well. So if you enter that password, it'll then make it editable that you can then update and add any other additional details that you need at a local level.
Yeah, and that's a fair comment, because often with Word documents, if you have photographs, they shift around if you don't have them PDF'd. Somebody else is asking whether people should be seen first for the first session face-to-face and then continue afterwards with tele-CIMT, or do you deliver the whole lot directly after inpatient services are finished?
I think it depends on the individual person, that there's no right or wrong way of doing that. Within ReSite, we are delivering the program 100% remotely. And that's again to assess the feasibility of that, because we want to see if this model could be used for people who are living in geographically quite isolated areas, or if we're in a situation again where there were significant lockdowns where we're not allowed to be having face-to-face contact. But very conscious that the situation with COVID has changed now. So particularly, and Kate will touch on this as well in her presentation in a moment, I think if you think that person would benefit from the first session being done face-to-face to help support them with the setup, absolutely go ahead and do that. And there's also no reason why the resources that we have on the website can't be used in a mixed model, a hybrid model where some sessions are via telehealth and others are face-to-face. It's really just working out what will work best for that particular individual and what's feasible within your existing service.
Okay. I think that's all the questions for now. Thank you.
Thank you. I'll just be one moment whilst I bring up the recording.
Just pause it for a second. So there's one more question for somebody, and this is not so much about tele-rehab, but have you had success delivering CIMT in an acute environment where people tend to stay, well, they don't stay for 3 or 4 weeks in a lot of our acute environments. It's 3 or 4 days sometimes. But yes, you have done CIMT in those situations, haven't you?
Yes, I have done. And we have a number of the teams that were involved within Active Arm were delivering CIMT within an acute setting who had some quite positive outcomes. For those teams, short length of stay is very much a challenge within stroke rehabilitation nowadays. I would particularly encourage you to have a look at your pathways to either inpatient or outpatient rehabilitation services and look at where you can build partnerships. Some of the teams that were most successful within Active Arm were those services where the the acute therapists started the CIMT program and then handed over to the rehab service, who then continued it through to the end of the 2 weeks. So I handed over the workbook and provided a clinical handover where they then saw that program through to completion. So that's one potential way of working through that potential challenge, either partnering with inpatients or outpatient services. We also had another service who was seeing people at an inpatient level. If they went home and they hadn't quite finished their program, they would come back into an outpatient group to finish that through to completion. And finally, I think it's also worth considering whether people receiving some CIMT is better than none. Now, realizing that if you're not delivering a program with fidelity or reaching the full 2 weeks, people might not get quite the same level of benefit. But what we do know is that this is an effective intervention. So if people are eligible for it, they're suitable for a program and they're willing to participate, thinking about whether delivering this more intensive model, even if it's for a short period of time, may be more beneficial than them not receiving it at all.
Okay, thank you.
When COVID started and our need to rapidly change. Hi, and thank you very much for the invitation to present on my experience with telerehab. What I thought I'd do tonight is start with when COVID started and our need to rapidly change and adjust to telerehab, and then talk to what's happening with telerehab now. So what's the current state of play? I think before we start, it is important to just stop and reflect on the evidence for telehealth. And when we look at the evidence for telehealth, there's pretty solid evidence from lots of stroke survivors summarised in a Cochrane review that says telehealth is equivalent to face-to-face therapy. Now, it's likely that in most of these research papers, they've picked people who would be really suitable for telehealth. So they are picking people, who are really adaptable to telehealth. But still, in those people, it is equivalent to delivering therapy in a face-to-face way. And that's across a whole lot of different types of therapy, including arm rehabilitation, mobility training, and more health coaching kind of interventions. So it is really important to remember that. Telehealth is really about doing things differently, but I think we need to make sure that we're reframing it and understanding that it's not an inferior approach to delivering therapy sessions. So now let's talk through my experience of telehealth. So this is really about, practical solutions, not from an evidence-based, but from what we found. And in the disability service provider that I mentor, we really had to flip to telehealth very, very quickly, because like any private therapy organisation, it was really critical that we could continue to deliver therapy from an organisational perspective, but also with the people with disability who we support, it was really important that they could have some ongoing support through the pandemic and through the different waves of lockdowns and restrictions. So I guess when you're thinking about the use of telehealth, you have to think about what platform you're going to use. And we use two main platforms. Initially, we focused our service on a platform called PhysiTrack. And interestingly, we learned a lot of lessons, even though that's a very, very good platform. The clients that we work with didn't prefer it. They very much preferred Zoom. I think in that time, Zoom became the platform that everybody was using. And so it was what they were requesting from us. But PhysiTrack really has some nice advantages. And here it is on the screen in terms of the interface, which is pretty typical for most kind of telehealth platforms. But what PhysiTrack allowed you to do was embed a home or an independent program and actually track people's completion of that program over time. And it allowed some messaging or interaction between the therapist and the client. So we thought it would be very, very popular. But interestingly, as I said, Zoom was by far the preferred approach. So what I did personally when using Zoom was I actually set up a Google Doc between myself and the client, and I got them to actually mark their adherence in the Google Doc. And then the first thing we would do in the telehealth session is check the Google Doc together. So check what they've done. So I guess a less sophisticated way of checking independent practice. You know, it's a real eye-opener how much you need to help people with technology sometimes. So we developed a whole lot of resources around the use of technology. And often the very first telehealth session was really about orientating the person to technology and getting set up with the technology. And what I would say from my experience is it's by far more successful if you can do a face-to-face visit, a home visit or a community visit to actually set the person up on telehealth, set them up on their computer or their device in order to get everything working really smoothly for your next telehealth session. If you're able to do that, by far my preference. We had to develop a whole lot of other resources along the way, and one of them was around safety. So we had some safety guides, thanks to Simone. Simone put some of these together around home exercise safety, and then we created some online safety tips for therapists. So things to help therapists feel comfortable delivering what can sometimes be challenging exercises, remotely. And in the early stages where we were really moving from face-to-face sessions and then considering, well, how could we transition this to telehealth? We used this planning sheet. So what we did was we considered everything that happened in a face-to-face session and what could and what couldn't translate to telehealth. And I think what's important to remember is telehealth doesn't directly replace face-to-face. You really have to brainstorm and think about what you can do via telehealth, but also what you can't do via telehealth. And that is okay. It is okay if it's a different session to what you'd normally deliver face-to-face. And so even though we don't need to use these sheets anymore, I think that concept that telehealth is different and you can't directly carry over what you would do in a one-to-one session holds true, even to current day practice. It's important to note that we also ran groups via telehealth, and this is one of our very first groups when the COVID pandemic first hit. You can see the stroke survivors and myself and Laura, one of the other physiotherapists. And the group took even more planning, to be honest, because what we really needed to think about was how a group might work online. And we had to give up some of the things we'd normally do face-to-face. So face-to-face, we had kind of gym equipment, but online we didn't. So we had to think about what we could replace that with in the online environment. And what we learned along the way was actually we were a little bit too intense at the beginning. So we kept getting feedback from the participants, and, they actually asked for a longer kind of welcome and more of a warm up before they got into the intensity or into the exercises. I think it's harder to read how hard people are working online. And so what we started to do was introduce regular check-ins where we'd put the board on the screen and ask them to rate how hard they were working so we could really judge it across the session. And then we really included some more social time, so a cool down, debrief, socialization, because at this point in time, people really were quite socially isolated as well. And we were very, very lucky within that whole process to have some support from some of the top researchers in the area of telehealth. So Professor Tash Lannon and Narelle Cox were really crucial in helping to train this team, support us to develop the resources that I just spoke about, and support us to start to implement telehealth. And so this is the publication of the implementation project we did. In this project, we surveyed staff before and after a 6-week training program. We picked peer leaders within the organisation who would really champion and support the idea of telehealth. And as I said, we were very lucky to have expert support to do this. We used a model of behaviour change to really help us. Sometimes this stuff can be a little bit hard to digest, but I think if you look at the wheel on the screen, what it does is it really gets you to think broadly about the implementation of something new. Think beyond the therapists and their skills, which is obviously part of it, but also to motivation and to opportunity, how well it was being promoted throughout the organisation. So I guess what I want to reiterate is you really have to think widely about all the aspects of doing something new or of changing your behaviour when you're implementing it. And so within this study, 32 therapists completed the questionnaires. They did identify some barriers to telehealth, their knowledge of telehealth, the environment, and their belief. They believed that face-to-face therapy was better. And then we did sessions every week for 6 weeks alongside developing the resources. And this slide summarises the aspects that we kind of used to intervene within the implementation study. And interestingly, what happened was that the use of telehealth increased dramatically. So lots and lots of therapy sessions were being conducted via telehealth, but the clinicians' beliefs didn't change. And that's really interesting. And whether, if you measured it again now, they may have, this was only a 6-week intervention and it was right at the heart of COVID lockdown. So that may have impacted on it. So I think this is all very interesting. It's great for me to reflect on that period throughout COVID, but it's also interesting to think about, well, where have we landed now? So what's the current use of telehealth? And I wanted to give you a really accurate answer to this. I didn't want to just make it up. So I did an informal survey across the organisation to understand what the therapist's actual use was these days. And you can see that it was a multidisciplinary sample of therapists across a number of different disciplines. So are they using telehealth? Well, about 70% are currently supporting clients via telehealth, which is pretty high, really, if you think about it. And what's encouraging the use of telehealth? Well, there was a really strong theme around decreasing travel or the client being remote from the therapist. So I think around 66% of therapists responded that that was encouraging the use of telehealth. And alongside that was that kind of aspect of convenience. So it was much more convenient. And you can see some quotes on the slide that really reflect that. I think the other thing which was quite impressive to me is that therapists were thinking about what type of therapy was supported well by telehealth. So they say, well, sometimes when I just need to review a client, or when what I'm doing is actually health coaching, that is really easy to do via telehealth. The therapy suits telehealth, and therefore I'm implementing telehealth. And I think it's really cool if we're getting to that point. There are a number of factors that limit the use of telehealth. So for many clients, they said that actually the client did better in person, or they actually preferred an in-person session. Or again, they reflected that the therapy didn't suit telehealth, that it was much, much better as a face-to-face, things like a swallow assessment. You needed to be physically there to actually assess the client's swallow. Again, fantastic that we're thinking about the clinical relevance of telehealth. Again, really interesting to see that technology limitations were reported really, really low. So there are very few instances where technology is now influencing or limiting people's use of telehealth. So if I went to my top tips, I think it's great if we can choose the right client for the right intervention, so we can start implementing telehealth when it is relevant. And that can be a combination or a hybrid between face-to-face and telehealth. You really have to plan for telehealth. You can't just wing it, as you can sometimes do in face-to-face. So you really have to think about what you are actually going to be able to do via telehealth. Where possible, assess first in person and set up for telehealth in person. Really, really sets you up for success if you can do this. I really like to send the clients a plan before the session, whether it's in an email, in a Google Doc, but list for them the equipment they'll need, where they need to be in their home, etc., etc. And then you've got to execute it. And I think there's no doubt that it takes more energy and more commitment to deliver a session via telehealth. It's a bit like teaching. You teach a live lecture, you can read the room. You teach via Zoom, it's a little bit harder, and you've got to bring the energy to do that. Exactly the same with telehealth. But I think we're moving to a really nice place where we can really have a hybrid model of telehealth along with side face-to-face. And we've got a lot of health professionals getting very, very good at telehealth, making it really, really effective in the sessions that they are delivering. Thank you very much for your time, and a big credit to Lauren Christie, who will now answer any questions you have about this presentation.
Over to you, Lauren. So yes, Kate couldn't be with us tonight after planning the date. So a recording is another way of us getting information about Kate's projects. So we've got one question there, but it's
I was halfway through typing an answer, Annie, so I might, but I'm happy to answer it live. So the question was about, in my opinion, if there are any patients too good for CIMT, for example, the patients that are advised to use the affected arm as much as possible at home and given a list of some activities to try. So I think there's a couple of key considerations within this. The first being, do some informal observations and see if the person has any learned non-use of their affected arm. So are they incorporated their affected arm and hand into all of their routine day-to-day activities? People can often perform quite well on structured standardized tests, but then still may not be using their affected arm in all their day-to-day tasks. So sometimes doing a bit of observation without them knowing that you're kind of quite watching for that can give you a bit of an idea as to whether they have learned non-use of their affected arm or not. The second important point that I was just typing is the consideration of some of the findings from the Quackle systematic review of CIMT that was published in 2015. They completed, as part of that analysis, a review of 6 relatively high quality randomized controlled trials that looked at forced non-use of the affected arm, which I think is in alignment with what you're describing. So where you simply place the mitt restraint on the person's non-affected hand and encourage them to do as much as possible with your affected arm. And there's not the structured program that we have within CIMT, the structured progression of activities or use of the transfer package. And what they found within that systematic review is that didn't have an effect on upper limb outcomes in terms of people's amount of use of their arm, their self-reported quality of arm movement. So just putting the mitt restraint on and encouraging people to do as much as possible isn't likely to have the impact, which is why it's important that we're delivering programs with all of those core components of CIMT. In relation to whether there's anyone that's too good, I know the Taub Clinic in the US uses a cutoff score within the motor activity log. Within my own practice, though, I've had people who've benefited from programs who have a higher score than that cutoff if they're really motivated and have some high-level goals related to their arm and hand use and supporting use of their arm to, say, get back to some certain work activities or handwriting or cutlery use. So I think some of that's dependent on the individual person and what their goals are.
Sometimes people can just be a bit slower with some of the tasks. So we've just run a workshop over the weekend in Queensland, and we had a couple of people who did have very high level goals for their hand, being able to do their hair up well in a braid or in a ponytail and do that in a reasonable time, doing shoelaces, those sorts of tasks. So you can do a really thorough interview and usually find quite a few activities that would be appropriate for inclusion in CIMT. There's a couple of other questions that we've answered in the chat, and the recorded lecture may not pick up. So somebody was asking about, has CIMT been trialled on participants where English is their second language? And Lauren has said yes, including First Nations participants in Southwest Sydney. I don't think they feature in the research articles much, as far as I can tell. And often the resource materials are not available in other languages. In some countries, I'm sure they are. And Lauren talked about Dr. Arlette Duceline from Chile, who has been doing matching resources in Spanish as well.
As I'm sure Arlette plans to make those resources more readily available too through their university website. So I'd encourage everyone to keep their eyes out for those.
Yeah. And I answered one of the questions about whether there's trials that have included people with chronic stroke more than a year after somebody's left hospital. And yes, the Cochrane review from 2015 has over 40 trials, and almost all of those trials, except for a handful, include people who are many months and sometimes several years after their stroke. So that's typically the population that is included in the CIMT trials. Now, any questions from Kate's presentation? I think she gave some really good tips about getting started and preparing people for telerehab. And yeah, it's surprising how many people do have technology. That we often think older people won't have enough technology or skills to be able to use that mode of delivery, but quite often they have somebody else in the house who can help them.
Mm-hmm. And I think that was very much a point when Kate and I have spoken about this topic together before, Annie, that's resonated across both of our experiences has been the importance of supporting the preparation phase for transitioning a person to receiving telerehabilitation, that if there's an opportunity to do an initial face-to-face visit to help with things like that environmental setup and preparing the person for a program, if you have some admin or assistant support where maybe someone can do a practice run of connecting to the call, if someone's less familiar with using the technology, they're all strategies that can just help you with maximizing the potential opportunities for success.
The other advantage of telehealth is that if there are particular professionals who have expertise, who happen to not be in the city that you live in, you can access those experts by telehealth. So I know a colleague who lives in the north of Queensland in Australia, whose child needed stuttering therapy and was able to access that from somebody in Melbourne because they were offering distance mode rehabilitation. So it does mean that you have much more access to people.
Absolutely. And I think even with Recite, what we've found, Danny, even within metropolitan areas, again, sometimes it's dependent on the activity and personal preference, but people having the opportunity to receive therapy in their own home, just with some of the challenges even around transport and parking and actually getting into the therapy centre, there's all sorts of benefits of being able to just do it from your own home that can be far less stressful for the person and make better use of their time as well.
Yeah, I think some of us have got used to having GP consults by distance, and having to go in is a bit of an inconvenience now.
Absolutely.
I don't see any more questions coming up. We'll give people another minute, but I think it's nice to finish a little bit early if we need to. Okay, well, I will say thank you and good night or good morning to everybody else. And the recording will be available on our website within a day or two under the resources tab.